So I'm Veronica Little. I work for the state of Utah. I'm with the Office of Substance Use and Mental Health. It's a very fancy title. Are you ready for this? I am the State Opioid Treatment Authority. Thank you. I appreciate that. Basically, that's a fancy way for saying that I work with people who provide buprenorphine, methadone. I also am over the state opioid response grant from SAMHSA. So lots of things that I get to participate in. So like many of you, I'm sure people ask you all the time, so wow, your job's gotta be real depressing. And I think that it's a hard thing to answer, right? But this quote often comes to me when I'm thinking about substance use, when I'm thinking about the things that we deal with on a day-to-day basis, that we have to accept the finite disappointment that comes. But we never should lose the infinite hope. So thank you guys for being here. Thanks for participating. And hopefully, even though we're gonna start with some of that finite disappointment at the beginning of what I'm sharing with you, we're gonna end with hope. So I don't know if any of you guys have seen this type of a graph or slide before, but this is the trends for overdose in the nation. So way back when we started all of this work on opioids, Utah was really, really highly ranked. We had a lot of overdoses here in Utah. We still do. But what we've seen is actually our overdoses have stayed more stable. We've had consistent numbers. The rest of the nation has just gotten more and more sick. They've had more and more overdose deaths. So the first wave that we had in this epidemic was with prescriptions. Still quite a few of our overdoses are based on prescription opioids. So don't think that that's gone and we don't need to think about it or address it anymore, we still do. The second wave was with heroin. The third wave was with fentanyl. We still see so much fentanyl, and the death and overdose is continuing to rise every year with fentanyl. But the fourth wave that they've been talking about more recently is with stimulants, and we know that we are so far behind the data. We don't get the data for so long that we're always trying to run and catch up. We've been seeing this. Those of you who work in the field have seen this for quite some time, but really when we're looking at death data now as we look back, this was starting in like 2015, where we started seeing stimulants only in our overdoses, which we had never really seen before. But we're seeing a lot of polysubstance use. So like I said, way back when we started with all of the opioid talk, Utah was 4th in the nation for overdose deaths. We are now 42nd. Again, that's better. We haven't improved. We've just not gotten as bad as some of our other states. So we want to keep working. I don't want people to lose the momentum that we've gotten. All of the great work that we've done, we've got to continue it and keep it moving forward. So Utah specific. So I work with some amazing humans, and I work with the medical examiner's office a lot. One of the things that I never thought I would ever do in my life is talk so much about death. Also about the weird nuances of what happens when people die. But because of these relationships, because of the work that we do together, I get some pretty quick data turnaround. So this is all provisional. So if you were looking at this, if you take a picture of it, please be cautious and be aware. This is provisional data up until June of this year. So this is the death data for Utah specific, okay? So what we can see over the years is that the trends for prescription opioids has gone down, but it is still high. We still see a lot of prescriptions being the cause of death. We've seen fentanyl kind of wave, or heroin wave in here. We've seen fentanyl skyrocket. We have also seen methamphetamine go crazy high. And again, a lot of these deaths are methamphetamine only. A lot of them are methamphetamine mixed with opiates. But what we are seeing now that some other states had seen previously was the rise in gabapentin. And I know that was discussed briefly yesterday, but we are seeing a lot more where gabapentin is involved. It's not the only substance in somebody's system, but it is involved. So when we break this down, who is it that we're actually talking about? Really, we are talking about people who overdose and die. More males tend to overdose and die than females. And we are seeing people between the ages of 35 and 54. That's a pretty big gap when you think about it. But realistically, what we see the most of is this 45 to 54. So we want to be cautious, we want to be careful. It doesn't mean that other people aren't at risk, but these are the people that we are seeing actually die. And then where are we seeing this? With who, again, I got ahead of myself, I'm so sorry. So this is a hard one for me, because when I talk about Utah, when I'm at like national conferences or I'm talking with counterparts in different states, Utah's very different than a lot of other states. And one of the ways that we're different is we don't have a ton of diversity here. And so I put this on the side because I wanted you to see the population and the census data for Utah. This is the percentage of people with their race. But these are the people who have had fatal overdoses in Utah. The people who are being affected by this is so disproportionate to the population that we have here. And we need to be aware, we need to be culturally competent and sensitive to that. We need to make sure that we're targeting individuals who might not have the resource. And then here's the one that kind of hits home right now for me. Where are these overdoses happening? And so we're looking at this by rate. And the rates that we are seeing the highest, right here. And it's been that way for quite some time. And we've made improvements, but we still have to keep working. We still need to continue with the work that we're doing, because we are making a difference and we will continue to make that difference. We need to make sure people have access and know what's going on, what to look for, and how to respond. The areas that are really most impacted are rural areas in Utah. I tend to forget how rural and frontier our state is because I don't live in a rural area. And so I'm not always the best person to say, hey, how can what's gonna make the most impact in my area? I can give you lots of data, I can give you lots of information, but really the answers are coming from you all. This is something that we have to partner with and collaborate on to figure out what is gonna work for where you are. So this is where I think most people don't get information from or about, is not all overdoses are fatal. And I have to say, thank heavens, because we would be in a lot of trouble. So I want us to remember the overdoses that are not fatal. When we see people in the ED, so I guess, let me back up one step. There's a caveat to this data. This is emergency department data. We do not have EMS, all of the EMS data on this. A lot of people don't go to hospitals when they overdose. It makes sense, it's really expensive. If somebody is revived, no thank you, I don't want to go. I get that. So we only have the data for when people are going into our hospital systems at this point. We are working to get better data and more diverse data. But when we're looking at this, the overdoses we're seeing, a lot of them are undetermined. They don't know exactly, or there's so many substances they're not sure what the overdose was caused by. So that's why we see the huge spikes in the total drug overdoses. We are still seeing more opioid overdoses in hospitals than we are for heroin or stimulants. Some of the reason for that is people don't always know what to look for or what happens, especially with stimulant overdose. Overramping is something that is not as common knowledge, and it's stuff that we should be talking about more and more so that we can help protect people, keep them safe. Our overdoses decreased, they dropped here. There's a few reasons that we can assume based on this. Part of it was COVID. Part of it, honestly, I think we did see a decrease in overdose deaths as well in 2020, 2021, started coming up a little bit. But I think that people had this shared collective experience that was really tough. And I think people tried to reach out more and connect more because they were feeling so isolated in their own ways. So in some ways that helped bring people together. It helped reduce some of our risk. But we're seeing it coming back up again. We still see, just by a smidgen though, more males than females who have non-fatal overdoses that show up in the hospital. But we are also seeing people within that same age range, that 35 to 54, are being the most impacted by overdose. So again, we need to educate, we need to have interventions, we need to teach people, but people who are at highest risk are between 35 and 54. So the last data point I'm going to share with you today is about dispensing rates. So we talked about prescriptions, that being how Utah really got led into this problem. It's still high. We are still having so many opioids prescribed, and that's not always a bad thing. People need medication, and that's okay, but we don't need an excess of medication. We don't need 112.5 per 100 prescribed. We don't need that many. We need to have alternatives. We need to have ways to manage and monitor our pain, and we need to have ways to help treat chronic pain and the emotional distress that most people are feeling that exacerbate the pain, right? So we need to have access. We have ways and things that we're doing to help with the prescriptions, and we are making progress, which is awesome. I'm really excited about the progress we've made, but we still have further to go. So, big question. Now that I've shared all of that death and morbidity data with you, what do we do? Are you all stumped? Don't be. Don't be. Here we go. We are going to talk about really what all this is and what we can provide. So I like to think of all of this as really just a continuum. There is no prevention, treatment, recovery, really. It is all a continuum of who we are and where we are, okay? So when I'm talking about it today, know that that's the lens that I'm coming at it from. It is all a part of prevention for us to have healthy, safe lives. First way that we can do this is really by reducing the factors that increase risk. We just had the lovely presentation about ACEs, what those are, how those actually pose and create higher risks and problems for us throughout our whole lives. So we can find shared risk and protective factors. We can help manage them. We can teach people how to deal with that. You know, I don't know who came up with this cost savings number, but they were super smart. Somebody much smarter than I am. So I always refer back to it. For every dollar that we can put into prevention efforts, it is like saving $36 when it comes to healthcare, when it comes to behavioral health, law enforcement, social services, all of that. If we can invest and we can help people from the beginning, it helps the outcome overall for so much. Want to help support that. Way to go, people. One of the ways that SAMHSA, one of our great partners, thank you SAMHSA, appreciate you guys being here. They have some really great toolkits and some tips and taps, all of those things for providers. But this one is about engaging community coalitions. Thank you guys for being here. Thank you for the community coalitions and the efforts that people are putting into creating events like this, because this is what we need. Some of the other ways that we can reach out to our communities is through media campaigns. Have any of you heard of Know Your Script? I hope, please, somebody. Oh, yay, I see like a couple. Thank you. I appreciate that. If not, check it out. There are a lot of different things in there. So it talks a lot about the prescription side of this, but really it's how do you talk to your doctor? How do you talk to your kids? How do you start these conversations? Because they can be difficult for a lot of folks. SAMHSA also has a new app. It's called Talk, They Hear You. And it is so awesome. It is so helpful. I'm a big fan of the QR codes. If you want to scan it, get that for yourself. It's a great app and it gives you step-by-step instructions. It helps you to talk about these difficult conversations. I don't know quite what to say about this. I don't want to tell too much, but I don't want people to not be aware. These are the things that we have available that can be helpful. Based on this, something that is super important is you need to tailor interventions and things to your community as well. So, some of the ways that we do that are through community coalitions. We do it by partnering. So community take-back days, we talked about, this is the wrong date, I apologize. This was from last year. I took the wrong slide picture and I'm so sorry. So pretend that's an 8 right there. The take-back days, partnering with communities to actually increase the people who attend and give back medications. I don't know about you all, but my mom is super good at going to the pharmacy and filling a prescription when she gets one. She is not super good at taking them all. She is also not super good about getting rid of them. One of the easiest ways that people have access to medications that are very damaging to them is in their homes. So we want to make sure that we are getting rid of medications if we aren't using them. It's okay to have them, use them as needed, use them as prescribed, and then get rid of them when you're done. We also have ways of working with communities about what really is going to be impactful for your community. Something that works in Salt Lake might not work here, and that's okay. It doesn't mean that it's a waste. We tailor it. So one of the things that was really awesome that happened in Duchesne, they had this amazing kit building process. They did a marketing campaign, and they talked about Cowboy Tough, how to talk about not having pain medication or what are the alternatives. These are things that we want to see and we want to help support because we want it to be impactful where you are. Okay, another great resource is this overdose reduction continuum of care approach. So some of the things that we really want to look at and identify, and we do this through all of our services, hopefully, is we are going to provide prevention education. We are going to ensure that that includes naloxone. We are also going to start implementing and finding ways to make access more available for medications for opioid use disorder. We are also going to be talking, again, all of these things happen simultaneously, about safe prescribing practices and alternatives. So there's not just campaigns to talk to people so that they don't end up using or misusing substances. There are also campaigns about what happens if somebody has a problem, what happens if there's a concern. So this is a little snap of Stop the Opidemic. On here they talk about a lot of really great things. They have many resources available. It's really helpful because sometimes you move from one point to the next point and you're like, ooh, now I really don't know how to talk about this. So there's key talking points, there's ways to reach out and be helpful to individuals. Shout out to my friend Riley up here. He's a fisherman. Also gives back, teaches about naloxone, gives out kits. Talk to him if you need it. Other media campaigns. People get scared. Stigma holds us back in so many areas of life. And so I think that people have this concern, if I have naloxone, I'm giving people permission to use. I don't know how to use it. My loved one isn't doing that. We don't always know. It is so much better to be safe than sorry. It doesn't have to be scary to have medication to reverse an overdose. It doesn't have to. And heroin pills, it all kills. All of it. It's non-discriminatory. So we want to make sure that things are palatable, things are approachable and accessible for everybody. We also need to talk about communicable diseases. We are not just talking about overdose, we're talking about helping lives be more healthy and sustainable long-term. So that means we need to have rapid testing, we need to have appropriate testing, we need to have access to it, and then we need to have treatment. People do not need to die from hepatitis C. Just want to throw that out there. There's a lot of interventions that we can do if people know, if they get tested. When we have the knowledge, we can do something about it. Syringe service programs. I think one of the things that happens most that I get to have conversations about are about syringe service programs. People get very up in arms and very concerned and very stuck in their opinions when oftentimes they don't know what it actually is. They've never been to a syringe service program or provider. They haven't engaged in any of those services or they don't know what they offer. Because I'm just gonna tell you, it's amazing how much resources are given out by syringe service programs. So many people have resources to vaccines, to testing, to clean supplies, to condoms. They also get referrals to treatment. This is amazing. It's such a great service, and we don't have any other way that we're reaching these high-risk individuals to try and help them to stay alive. They can be a really great resource, and it doesn't have to start out with syringes. We can take some steps back and have people start with other advocacy and outreach and open up to additional possibilities if they are needed in the community. So, I bet you all were waiting for when I started talking about naloxone. It's super awesome. There's a couple different ways that you can get naloxone. It's actually becoming more and more available. They just made it over the counter. If people have the finances, that's awesome. People can reach it, people can access it. You don't even have to have a prescription. But there are also ways that you can access it if you don't have the means or the access to go to a pharmacy and pay for it out of pocket. But one of the things that I always want to remind people, there comes Every kit comes with 2 doses. That is so important. We want to make sure we're able and ready to use both. If I am overdosing, I am not going to be able to give this to myself. So guess what? I should also be talking to my friends and family, telling them about it, giving them access, because they're going to be the ones that save my life, right? So we want to make sure we assess a person. Call 911. Please call 911. Even if the person doesn't end up going to the hospital, please call. We want people to stay alive and be okay. Start rescue breathing, administer naloxone, and then really monitor and support them until we know that they're stable. Pretty easy. Not too intimidating, I hope. So we also want to make sure that we're increasing access. So how many of you have ever tried to deal with insurance? And you all survived. I'm so proud of you. I feel like when I have to deal with insurance, I am almost like not going to survive it. It is so complicated. It is so complex. And I'm telling you, I work for the state. I should have like stellar insurance, right? I should be able to navigate this easily. It is never easy, folks. It's never easy. But there are people, we like to call them insurance navigators, that are there to help people sign up for, get insurance, and be able to find options that are actually going to work for them. So we want to help support that and encourage people. There are also trainings to help individuals become insurance navigators. Some of that's through the Utah, oh my gosh, Health Policy Project. Almost forgot their acronym, that was horrible. But they are so great at helping people. They will send people to train. They provide insurance navigation themselves. We want to make sure people have access, because if you have access to an insurance program, you have more access to services. We want to make sure that's out there. Once you have access, you can go into somebody. We work with providers about screening, brief intervention, and referral to treatment if needed. So have any of you guys gone to your doctor's office or a clinic and they give you like a little iPad or a paper or whatever, and they're like, have you had anything to drink in the last 30 days? How often have you drank? Did you drink 1 or more glasses a day? Have you used any prescription medications that weren't prescribed to you, right? Have you guys done this, or is it just me? Oh, thank heavens. Yes, Espert's working. That is Espert. That's what this is. They're doing screenings. Does that mean if I answer yes that I'm in trouble? No. What it means is I can actually have a realistic conversation with my healthcare provider. I can talk with Dr. De La Garza or Dr. Hal over there, and I can be like, yeah, you know, I was taking prescriptions that weren't mine, but I don't think it's that big of a deal. And then they can start having a conversation with me. Well, when do you think it would be a big deal? How do you determine if it's a big deal or not? Do you need help with that? Are you open to information? Okay. And then they also can know that for my other medical concerns or problems, right? So we want to encourage screening, brief intervention, and if needed, referral to treatment, because these are all ways to help decrease our problems getting bigger in life. So finding any opportunity for intervention is important. We can start with the screenings that we just talked about. We can talk about safety planning, and what safety planning oftentimes looks like is peer support. Whether that's a certified peer support, whoop, whoop, back there, or if it's really me calling my friend. I'm struggling, I don't know what to do. I'm really bummed out, I'm having a hard time. This is also the very same plan and things that we use for suicide prevention, just in case you were wondering. Safety planning can also look like I'm not gonna use alone. I'm gonna make sure that I use with somebody else so that if I use more than I intended or if I have an adverse reaction, that they are there to help support me so that I can stay alive. And then having safe means, that means locking up medications if they are not being used. It means if somebody is having thoughts of suicide or self-harm, that we're keeping medications that could be harmful for them put away and giving them a dose every time they need it rather than just leaving them out. It's also meaning having naloxone available. Once we've started into this whole process, this is really where I think I get most excited. And that's in addressing the protective factors in a comprehensive way. Because there's not one thing that keeps me safe. There's not 2 things. It is a whole crap load of stuff that has to all come together. And then once that's in place, I feel more supported, I feel safe, I can make changes in my life. So what we want to look at is we want to look at education. It's so important. That doesn't mean that everybody needs to have the same level of education, but we need to have education available for individuals. We need to have emotional regulation, which is so hard. It is hard for me on a daily basis, so I need people to remind me about emotionally regulating. We need to have employment. We need to have substance use open programs and places of employment, housing. We need to have places that are accepting and willing to work with individuals with where they are. And then we need to have some problem-solving skills. We want to make sure that we can reduce family conflict, that we can maybe work on our relationships so they're not such a large contention or a place that, thing that tips us over the edge where we're not doing well. We want to make sure that we have connection both with our family that we are born into and or the family that we choose. It doesn't really matter who we identify as family, but we need to feel that support, that love, and that connection. We want to make sure that communities are ready, that communities are prepared to be there for each other. That's a hard one. I think that's one of the ones that we struggle with most. But I have been so surprised and continually given more hope every time I go into a community and hear how much has gone on, how much has been pulled together, and what people are willing to do. So I'm going off on a little bit, I apologize. 4 years ago, I think Megan and I realized it was about 4 years ago, we came down here when the methadone clinic was just starting to open. And we went back to it this morning. We're like, hey, we just wanted to visit, see how things are going. We wanted to see the new layout. We hear, we know you expanded a bit. It is incredible to think that just 4 years ago, people were so nervous and concerned and apprehensive about having a clinic and a program available, and how great it is. And it's thriving, it's doing well, and people are getting support. That is community and neighborhoods coming together. That is people being willing to say, we love you and we want to help support you. How can we support you? Do you need transportation? We'll come pick you up, right? That's what this is. And then really, the biggest thing that we have to work on is the social norms, the cultural norms. We need to change that, reduce the stigma. We can all keep working on this all the time. So I'm not going to get into this too much because we had a wonderful presentation about the pharmacological aspects of opioids and medications for opioid use disorder. But this is so important. We need to make sure people have access to medications and the medications that will work for them. One medication does not work for everybody every time, and that's okay. We don't expect that from antibiotics. We can't expect it from this either. So having people who are trained, who are able to provide this service in your communities is so important. But it's also a barrier. I'm being real honest and real critical here. We have people who are worried to do this. I've talked to so many providers that say, I don't know that I can go into substance use disorder treatment, that I can start prescribing for that, because medications are what got us into this problem. And that's all coming from fear. That's coming from stigma, right? We need to be able to open up, have these conversations, and then connect people. You have no idea how many times I've been like, hey, do you know this lady named Beth Powell? She is awesome. Let's connect you with her. Let's get you some more education on this. Because I might not be the right person to educate you and teach you on it, but I can connect you with folks who can. This is a map of where all of our MOUD prescribers are throughout the state. We're missing a lot. We gotta keep working on this, and I want you guys' help and support too. Talk with your providers, talk with your actual private providers and say, hey, do you provide this service? Have you ever learned about this? Are you willing to? It's so important, and it can be just, we gotta start opening that door somewhere. So let's all work towards this. This is a very boring slide, but that's okay. It has a very important point. One of the things, and I know we've talked about it briefly at the summit here, people who are incarcerated, we have a really great opportunity to offer support and to offer access and open up access to individuals who are incarcerated. Part of the way that we can do this is by being able to start doing treatment there, whether that's medication, behavioral health services, or both. Both is awesome. If we can get there, let's do that. If we can't, that's okay. There's a toolkit that is amazing, and it teaches people, it literally breaks it down. It's an a la carte menu for people if they want to start services. Hey, if you aren't ready to have methadone open in a jail, that is fine. Here are all of these other things that you can also implement and do. It's like a pick and choose, which is great, but it all has to start with having somebody who is a champion in the community, having stakeholders being willing to say this is important to us, and we want it to happen. We had a bill passed, Senate Bill 111, in the last session that allows every incarcerated setting to provide MOUD. Yay! Woo! We love this. What we don't necessarily love is there was not funding attached to that. But we're working on that, and we have ways to help start that. But again, we are starting, we're opening those doors. We just gotta keep pushing them open further and further, letting people in. We have a public system here in Utah. We have 13 local authorities that provide public service in their catchment areas. So here are the catchment areas, how they're all broken up. People who are unfunded or underfunded can get services through them that are also supplemented through grants and funding through the state. It's really awesome. These guys have a huge responsibility. So Four Corners, I know y'all talked a little bit earlier. Where are my folks at? I see you back there and over here. They've got a big responsibility because it's not just one thing that they're being asked to provide. It is this whole continuum that I'm talking about. They are responsible and are responding to all of these needs in our areas. And they want to help and provide services. They also want to partner and support each other because it's not just a public provider that's doing it. These are also private providers that we need to link people to, right? There should be no real distinction. If somebody has funding, we need to get them in. If they don't, here are some other options, right? So reach out to your local providers. If you need help connecting to them, call me, email me, I will get you connected. It's a great give and take that we have here. Don't know if you guys heard earlier today, but there's this thing called AccuDetox.
Let's go.
Don't know how many of you also participated. It was very soothing for me, thank you guys. One of the great things that I get to do in my position is I get to hear about new and innovative projects in programming, and I get to also work with ways to find funding to get things started. Now, we can't rely on grants to fund things forever, but we can pilot things and we can get them started. We can help people get some sustainability, and we can also help train folks. That's one of the biggest things that I'd love to do. We want to train, provide resources for you in your community, so then you don't have to go reinvent the wheel. It's already there. You just keep using it, keep going. Again, we heard from some of these folks earlier today. They're awesome, good working, good humans. Our peer supports are amazing. Peer supports aren't just at USERRA, but USERRA has really started putting peer support on the map here in Utah and helping support it, get it going further and further. And peer support services are just awesome. You guys have heard so much about them. You've met the folks who do that in our community here. And in St. George earlier today, they were all on the panel. But they do so much. Holy crap. When I think about all the work that gets done as a community recovery organization, it makes me tired because y'all, these guys are working so hard and they're doing so much, and it is awesome. And for a lot of people, it continues, it keeps them good, it keeps them giving back, it fills them with joy. So keep doing the good work. Help support them. Make sure that you get involved. Something that doesn't often get talked about is people who are the helpers who need help. So people within our medical profession and our substance use treatment realm oftentimes find themselves in need of support and help. And there are programs out there and available. There's programs through DOPL so that people can keep their professional license while they are working on a struggle if they might have one. So always want to make sure that people are aware of those supports and those services because we need people in our system. We need people to be able to work who understand what's going on and who are dedicated to it. And if you're struggling, that doesn't mean you have to give everything up. It doesn't mean you quit. It means that you can keep working. So some call this postvention. I think it is a postvention, but I also think it's prevention. What I'm talking about here is grief and loss support. So when somebody does die by overdose, that is really traumatic. It is very, very hard. And the people who are left behind still struggle and they need support. And we have historically not been great at dealing with that. We've worked with Caring Connections for 4 years now on grief and overdose based, or grief and loss based on overdose specific programming and trainings, which I think is so incredible. It really, when somebody historically had lost somebody to overdose, it felt weird going to a sudden loss group, because oftentimes those people had died by suicide, people had died from cancer or a car accident, and that was very tragic and it was unexpected, but it felt different and people didn't feel like they were getting the support or understanding that they really were looking for. And so we've been working with Dr. Supiano to create this manual really focused on grief and loss from overdose death. It's an amazing program. And she provides the training for individuals throughout the state. Please reach out, please get trained. It's so important. I don't think there are many people that I've met in life, period, who have not been affected by overdose death. So we want to make sure that we are responding to that need. All right, guys, I'm gonna wrap this up for us. I told you I'd get through it. We're getting through, I love it. Where do we go from here? We gotta reduce the stigma. Stigma is so hard. There's so many ways that we stigmatize ourselves, that we stigmatize others. A lot of it's unintentional. We don't know that we're doing it at the time, so we do better when we know better. So help support people, let people know. We don't have to call people out. Dr. Marcella Smith is a good friend of mine. She's hilarious. She's a lovely human, and she's like, we gotta call people in, VaRonica. We gotta call them in. Get them to come and talk with us in a way that's less divisive. How do we call people in? We do that by reducing the stigma and talking to people. We need to increase awareness. I think still there's a lot of folks who think that's not a me problem, that's a you problem. This is not something that's gonna happen at my house or with my family or with my friends, and it is. So we have to continue to increase that awareness. And then really look at how we support people. We need to find better ways to connect housing, education, and employment to people who are looking to start recovery. Thank you, I appreciate that. I don't have the answer to it, but we gotta keep working on it, right? Because there are ways that we can fund this. There's ways that we can connect people, but we have to do better, we have to do more. Because who can stay sober if you don't have a place to live? If you don't have an ability to work and provide for yourself, right? Again, continuing to increase access to services, which includes those who are incarcerated. And then we need to really look at expanding our death investigation, because we can learn so much from the people whose lives we lost. It is tragic and it is horrible, and we don't want to lose people's lives, but we do. And we can learn from that. How can we better provide interventions? What other ways can we offer support to folks so that others don't have that same end outcome? Enhancing the community-specific interventions, always important. And then using evidence-based programs, evidence-informed approaches. They're so important. There's so many things that we can do that are really helpful. Don't want to end or leave people without that hope, because we have to have that infinite hope, right? Prevention works. Treatment's effective. People recover. Yes. Thank you. Thank you. Coming together is a beginning. Keeping together is progress. Working together is success. We all do this together. We've got to keep doing it. So thank you guys for being here. Thank you guys for participating and sticking it through till the last speaker.